Hello, soon to be licensed nurse practitioners. This is Miss Cohen, and I'm introducing to you today the Nurse Practitioner Review Pregnancy. Pregnancy. Let me show you what we're going to discuss. Signs of pregnancy, obstetric history, calculations including Fundal height and Negel's rule, laboratory testing, drugs, categories A through D, including X, drugs that you need to know that are teratogenic. We're going to discuss emergent situation and complications such as placenta previa, placenta abruption, severe preeclampsia, and HELP. We're also going to discuss disease review such as RH incompatibility, oligohydramnias versus polyhydramnias, urinary tract infection, which is a very big topic, gestational diabetes mellitus, and terminology related to pregnancy. We're going to finish it off by talking about pregnancy health education, breastfeeding, and extra pregnancy stuff. Now, remember, guys, if you haven't watched my videos already, you know I keep things super simple to what you need to know, and I get rid of all the excess fluff. I want you to pay close attention to the things that I highlight in green. Anything green and bolded is key. Key, it's a clue. It's something that you need to be able to pick up on the test. It's a sign, a signal, a red flag that should lead you to understand or know the answer. It's key that you pick up on these green bolded letters. I'll show you. But let's get started. Let me show you what I got for you. So signs of pregnancy, there's divided into three categories. Presumptive, meaning that the mom feels these changes, but doesn't necessarily mean that you're pregnant. It could be other things. Probable means there are changes happening in the body, actual changes that are very likely to be pregnancy related, but not necessarily absolute, right? What's absolute is the positive. It's the 100% sure and proven that there's pregnancy going on. So let's talk about these. Presumptive. These are the ones that mom may feel and think that she's pregnant, but don't necessarily mean pregnancy. Amenorrhea, lack of a period, nausea, vomiting, breast changes, fatigue, urinary frequency, increase in body temperature, and quickening. Remember, quickening is that feeling that the baby may be moving inside of you, or it could be just gas, right? So all of these things could indicate pregnancy, or it could mean the mom is, or the lady is super tired from a long day's work or a week's worth of work, and she's lost her period, she's nauseous and vomiting, her breasts are changing, I'm not sure why, but she's so fatigued. She's got frequency because she's developing UTI. She has increased body and temperature because she's so stressed, and she's got gas, right? Doesn't necessarily mean you're pregnant. Probable means that there are some changes happening in the body, some physiologic changes, such as the Goodell sign. Goodell sign, you have to know these names, okay? The Goodell sign is a softening of the cervix. That's all it means. Could be pregnancy, it could be something else. Chadwick sign. The Chadwick is increased blood flow to the vagina and the cervix, right? Usually it's like 4 weeks into the pregnancy, but maybe there's something else causing increased flow of blood down there. I don't know what, but it doesn't have to be pregnancy. Hager sign. Hager sign is softening of the cervix in the isthmus. Isthmus. I can't say that for my life, but that's like a portion of the cervix between the uterus and between the vagina portion of the cervix. It's like an area. But yeah, enlarged uterus, or maybe she just gained weight. Ballottement. Ballottement is the technique of feeling and a movable object, right? In this case, the baby. What if it's a tumor? Cancer, right? And positive HCG. Now, that may trick some people because it not always means pregnancy. What if there's a hormonal imbalance due to cancer, a tumor? I'm always thinking cancer because I'm an oncology nurse, but that can cause increased release of the HCG, not necessarily because there's a baby, right? But positive, let's talk about the positive. Positive is absolute guaranteed there's a baby growing in that belly. So if you and I as healthcare workers that we know what we're doing, supposedly, if we palpate this fetus, right, that's a positive sign that there's a baby. Or visualizing it in ultrasound, right? You can see if there's a baby or if it's something else. and fetal heart tones, right? Nothing else sounds like a heart in your belly if it isn't your baby, especially when it's like so fast and so cute. So make sure you understand the difference between all three. Okay, let's talk about obstetrics history. You have to understand the gravida para terminology. All right, you may get a question and you have to say what would be the gravida para, the way to describe it. So let's talk about it. You have gravida, which means number of pregnancies. Now that includes abortions, miscarriages, whatever. It doesn't matter the outcome, is how many times the patient got pregnant. Term, for T, it's the numbers of deliveries after 37 weeks or full term. And preterm, the P, is numbers of deliveries before 20 weeks, so preemies. Abortion is for the A, number of deliveries between 20 weeks, induced or spontaneous abortions. And L is living, number of living children. So here's a small example on the bottom. This would be, let's say this patient, this is a tricky one because she had twins, but pregnancy, she was pregnant once with 2 babies, once, right? She delivered them at full term. There were no preterm, no abortions, and you ended up with 2. So gravida 1 for 1 pregnancy, full term deliveries 1, because you look at it as 1, and you ended up with 2 babies. Make sure you understand that and that you're able to decipher it or put it together if they give you a case scenario. Now, Negele's rule, right? They may give you information such as the last menstrual period, and you need to tell them when the expected delivery date will be. There are 2 ways of doing it that I know of. One is the last menstrual period plus 9 months plus 7 days. All right, an example would be January 1st, keeping it super simple, 2020. You add 9 months, that makes it October. You add 7 days and it makes it plus minus day 8. So expected delivery date, October 8th. The other one is last menstrual period minus 3 months plus 7 days, right? So again, the same example, and you just got to change the year, right? Let me see. Last menstrual period, 2020. So January 1st minus 3 months puts you back at October plus 7 days. So day 8, expected delivery will be October 8th of 2020. 2020, right? Did I do it right? Last menstrual period in January. Oh, yeah, I'm correct. Okay, so make sure whichever technique you use, you're able to figure out the expected delivery date. Nice and easy math. This is a great quick formula to put down in your dump sheet, right? The white piece of paper that the boards will give you so you can just dump the information. But make sure you're able to figure this one out. Now, when we talk about the fundal height, this is important. And I've mentioned it in other lectures. Because remember, the weeks pregnant equals the fundal height. So what I mean by that is, let's say the female is 12 weeks pregnant. The fundal height should be at by the pubic symphysis. You see how close it is to this area? The pubic symphysis is right around there. 20 weeks pregnant, it should be about the belly button. 38 weeks, and so is full term, so by the xiphoid process. And the reason why it's important, because if somebody shows up and they're, say, 30 weeks pregnant, but the fundal height is only at, let's say, 28, right? At 28 centimeters, then there's something wrong. Or actually, that's not a good example because it's 2 centimeters or more in uterine size. So let me say, give me another example. Mom is 30 weeks pregnant and the fundal height is at 18 centimeters. I mean, clearly there's a discrepancy there, right? It doesn't match. Way more than 2 centimeters. So that's growth retardation. And you need to refer this individual immediately, get them out because the baby's not growing okay. Right? Super easy, but know your landmarks, know your xiphoid process, know your umbilicus or belly button, and know your pubic symphysis, 12 weeks, 28, 38. So if the test asks you, where should the fundal height be at 18 weeks? Well, you kind of know it's somewhere in between the 20 and the 12. So in between the pubic symphysis and the belly button. Keep it simple. Laboratory testing, part 1. Normal pregnancy lab changes, right? You're growing an individual, so things will change. Alkaline phosphate will increase due to fetal bone growth. There's an increase of white blood cell count, also known as leukocytosis. Remember, leuko meaning white, cytosis meaning production of cells, as high as 16,000. So don't freak out. She's not having an infection. She's having a little child. The hemoglobin in the hematocrit may drop. It's so common for pregnant women to become anemic. It's almost because the blood supply or demand is increased, but the production is the same. So the mom's hemoglobin, hematocrit may drop, but you have to rule out iron deficiency anemia. So make sure you check your MCV and do a full iron studies panel, including TIBC, iron level, ferritin level, add a B12 and a folate too while you're at it, to make sure you're thorough. Your ESR goes up. And remember that the gold standard test for genetic disorders is testing for fetal chromosomal DNA. Now, you want to screen for genetic disorders like Ashkenazi descent, because common abnormalities for this population is Tay-Sachs disease, whites for cystic fibrosis, African Americans, sickle cell anemia. Okay, now amniocentesis and chorionic villus sampling happens between 10 and 12 weeks. It tests for fetal abnormalities. You check the HCG by week 8. It's quite accurate. And vaginal cultures. This is a big one. The group B strep. You want to check this by swabbing the vagina and the anus of the mom somewhere between 35 and 37 weeks, because if it is positive, you want to treat her with penicillin, right? Absolutely. Now, drugs, categories A through D and X. Let me be honest with you. And it depends on the resources that you study and you see what drugs fall under B, C, D. So you may find some discrepancies, but let's be real. You have to know what's safe. You have to know what it's not safe. And there's the stuff in between, right? There's a big difference between category D and category B, or category A and category X. Don't get too carried away between C and D or B and C, but understand that A is no risk factors to the baby whatsoever. So these are your prenatal vitamins, your insulin, levothyroxine, senna, folic acid, all right? Category B, animal studies, no risk, but human studies, no adequate studies have been made. Metformin, hydrochlorothiazide, you can read the list, right? I don't need to read it for you. Category C, animal studies show adverse effect on the fetus, but human studies, there's no adequate studies. So this is your gabapentin, amlodipine, trazodone, Bactrim, sulfa drugs, right? Sudafed. Category D, now we're getting a little spicy here. Positive evidence of fetal risk, but you want to consider the potential benefit, right, if life-threatening. So ACE inhibitors, ARBs, fluoroquinolones, tetracyclines, NSAIDs, and sulfa drugs, all right? This is getting a little dicey. And X, clearly there's absolute fetal abnormalities, adverse reactions to the fetus are known. You absolutely stay away from these Lupron, methotrexate, tetracycline, Accutane, Proscar, misoprostol, all the hormonal drugs. So definitely know your X, understand your A's, and everything else falls in between. Now, nitrofurantoin macrobid is a category B, but you definitely want to avoid it in the 3rd trimester due to an increase of neonatal hemolytic anemia. So it becomes riskier later in pregnancy. Antihypertensives, I do want you to know these, that methyl-dopa, calcium channel blockers, and labetalol are the drugs that we use in hypertension in pregnancy. So, and this is bolded in green, so you want to make sure you know that. Methyl-dopa, calcium channel blockers, and labetalol, okay? And drugs that you avoid in the 3rd trimester are your NSAIDs, aspirin, bismuth, and again, sulfa drugs. Bolded in green, this means you have to know. Back to the teratogenics, teratogens, or the drugs that cause absolute risk to the baby, prohibited, don't you dare. Alcohol, cocaine, lithium, Accutane cigarettes, right? Aminoglycosides, uncontrolled diabetes, believe it or not, and Paxil. So here, you can read those. Sertraline, citalopram, escitalopram, you want to stay away from. The other things that you want to be really careful, it's live vaccines, such as your MMR, oral polio, your varicella, and the flu mist. Do not give to pregnancy. There are vaccines that are safe in pregnancy, such as the flu vaccine and the Tdap, right? Hep B is okay because if it's safe for the baby, it's safe for the mom. But stay away from live vaccines. No good. No bueno.